Okay, welcome to this podcast for Chapter 21. This is the last podcast for the course. It involves healthcare reform. There are 17 pages of textbook that I would like you to read over. There are 22 slides in this podcast, and we will be covering 4 IRATs. There's really no tables, figures, diagrams to focus in on here per se. There are 3 objectives. In particular, why do we discuss healthcare reform? So we will focus in on the cost of healthcare, the access to healthcare, and the quality of healthcare. So all of these are of concern to the people in Congress right now as this is being debated. The cost of healthcare. Healthcare is right now 16.4% of the U.S. gross domestic product. Far more than most countries, and we have very poor outcomes for that type of money. Access to health care. What is the primary method to obtain access to health care in the United States? And that's usually involves some type of health insurance. There are other methods to obtain access. Those are delineated in the textbook, like free clinics. For like immigrants and so on. Quality of health care, life expectancy in the U.S. Is 81.2 years for women and 76.4 years for men. So you can see that women live 4 or 5 years more than men on average. There are federal efforts to increase access over time. Historically, in 1966, there was a Kerr-Mills Act that provided coverage for elderly indigent individuals, but this changed in 1965 with the passage under Lyndon Baines Johnson, president then, for Medicare. So social health insurance has coverage for those greater than 65 years, disabled, or with kidney disease. Medicaid in 1965 was also passed. It's a federal state program for low-income individuals. Now, a lot of people on Capitol Hill in 2017 are actually discussing expanding Medicare for all individuals, not just those greater than or equal to 65 years of age. If we did that, we would be very similar to Canada. There's been attempts to contain costs using different professional standards review organizations, peer review organizations, certificate of need requirements for capital improvements. You may not know this, but for example, with hospitals, if they wanted to have a capital improvement, for example, a helicopter pad out in front of the hospital, they have to have submit a certificate of need to the state and to the federal government, and or depending on the capital improvement, the federal or the state government, maybe even both. There's diagnosis-related groups to control reimbursement for Medicare Part A. We've discussed that before. There's attempts with HIPAA. We've discussed that before too. Health insurance companies must do these 4 things: not deny coverage due to pre-existing medical conditions as long as an exclusionary period of up to 1 year or 12 months for that condition. They must sell to smaller employer groups and individuals who lose coverage regardless of their health history. They must renew policies, and they must include patient privacy requirements in the law. So a lot of people think HIPAA really applies just to that last bullet. It's really all these 4 things. For the IRATs, I want you to know that focusing in on that do not deny coverage due to pre-existing medical conditions as long as an exclusionary period up to a year or 12 months for that condition. That's part of the HIPAA Act of 1996 that they must accept individuals with pre-existing conditions for within a 12-month or a year period. Moving on, there's the Medicare Prescription Drug Improvement and Modernization Act of 2003, provided for health savings accounts, Medicare savings, medical savings account. These are tax-free savings accounts used for out-of-pocket medical expenses for those who have high deductible insurance plans. And it kind of works like an IRA. It's just for health. The total out-of-pocket spending that is capped, however, at $6,650 for an individual and $13,100 for a family. Looking at the Patient Protection and Affordable Care Act of 2010 was to expand access to health services with the individual mandate. There's a tax penalty for those who do not enroll in the health insurance plans, so when they file their taxes at the end of the year, that tax penalty will show up. If they don't have a certificate that attests to the fact that they have health insurance. There's state-based insurance exchanges, Medicaid expansion under the age of 65 and income up to 135% of the federal poverty level. There's also dependent coverage for adult children to the age of 26, so parents can have their adult children to the age of 26 covered, depending on the circumstances. I want you to understand for the IRAT that the individual mandate of the Affordable Care Act does not say anything about requiring individuals to have a primary care provider. The individual mandate is just for the insurance, not for having a primary care provider. The Affordable Care Act, funding for increased access, employer and individual tax penalties. It reduces the amount allowed for contributions to flexible medical spending accounts. There's a tax on nonprofit hospitals failing to comply with the new requirements. And there's annual fees for pharmaceutical manufacturing and health insurance companies. Other aspects of the ACA, there's the National Quality Improvement Strategy, which uses quality measures to improve healthcare delivery, patient healthcare outcomes, and population health. They, like when we were discussing pharmacoeconomics, you can identify and conduct comparative clinical effectiveness research through the Patient-Centered Outcomes Research Institute. There's Medicare Part D. There's hopes to eliminate the coverage gap, that donut hole, by the year 2020. Pharmaceutical manufacturers can provide a 50% discount on brand name prescriptions. There's different political aspects of the ACA that were challenged in court. In 2010, the constitutionality of the ACA was challenged by 11 states. In 2012, the constitutionality was upheld by the Supreme Court, specifically the individual mandate and the Medicaid expansion. In 2015, tax credits for those who purchase health insurance in the marketplace was upheld by the Supreme Court. Other outcomes of the ACA: by March 2015, 16.4 million previously uninsured people had access to health care. This can be broken down: 9.6 million through employer-sponsored programs, 6.5 million through Medicaid expansion, and 4.1 million through the individual marketplace. There was a reduction in use of uncompensated care in hospital settings. There was a rise in health insurance premiums, less than the 5-year period before. And this seems to suggest that premiums are going down from 72 to 26%, but then they're starting to jump again up with 2016 and now 2017. Now, this may seem a little confusing here, but there were healthcare reforms that took place primarily in Massachusetts and Vermont that were used as models for the Affordable Care Act. People in Congress, some of the representatives from those states argued that Massachusetts and Vermont had some answers. So they looked at states like Massachusetts and Vermont. Now, some of this has gone away, of course, with the Affordable Care Act, but these were initially efforts by states to take care of these problems before the ACA was adopted. So, for example, in Massachusetts with Chapter 58, they had the individual mandate. It required employers with greater than 11 employers to pay a fee of about $300 per employee per year if the employer did not offer a health insurance plan. And there in 2006, about 97% of the residents were insured, which a lot of congressmen liked. Next slide, also involving Massachusetts, there were methods to address the cost of health care with the Special Commission on Healthcare Payment System. Recommended a change from fee-for-service system to an accountable care organization. And also in Chapter 224 in 2012, which was 5 years ago, there was a benchmark for growth of healthcare costs of about 4%. Outcomes, 50% of newly insured enrolled in private coverage through employer of the individual plan. Increase in employer-based health insurance coverage. The state has the lowest rate of uninsured individuals. However, and this is important, this is why the Republicans are arguing against the ACA, the state has the highest health care spending in the country. Now, switching to Vermont, which was another state that did some reform before the ACA, there's the Health Care Affordability Act that was created by Catamount Health. The premiums subsidized the premiums subsidized were based on income at or below 30% of the federal poverty level. In all of this, there was something called the Blueprint for Health. It addressed through a chronic disease management plan. The implementation was delayed, but in 2011 it passed. There was a statewide universal health system called Green Mountain Care. The financial projections most recently in 2011, 2013, and 2014, where the new taxes were estimated to be 11.5% of payroll for 2014, estimated $2.5 billion for state to fund the Green Mountain Care, but this was abandoned in 2014. Now, specifically focusing on the pharmacy profession and the Affordable Care Act, at the federal level, you can apply for grants for medication therapy management services to the Patient-Centered Outcomes Research Institute. So you can do studies on how pharmacists can affect medication therapy management services. At the state level, we can advocate legislatively for collaborative drug therapy programs. So we do have some that are here in New York. There are 6 teaching hospitals with some pharmacists doing collaborative drug therapy. These are more demonstration projects than anything. And there needs to be a groundbreaking to identify pharmacist-driven MTM services. Now, as part of that, I want you to know for an IRAT that there are not sustainable reimbursement mechanisms for pharmacists to provide MTM through the ACA, at least not yet. And that's an issue to lobby for. Finally, this last slide, reforms for pharmacy profession. We want reimbursement for pharmacy medication management services. We want collaborative practice laws to improve here in New York, to recognize pharmacists as providers of healthcare services. Right now at the federal level, we're not recognized in the Social Security Act. Physicians are paid through Medicare Part B. Why can't pharmacists? There's proposed legislation on the docket to amend the Social Security Act to recognize pharmacists as providers. That hasn't happened yet. And with that is the end of all of our podcasts. Thank you.